Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast
With your hosts,
Z.
and John.
Good morning, everyone. Good morning, John. How are you?
Good morning, Zara. Really good.
Well, I did a bad thing. I was up till 2 a.m. watching a show called Monsieur Spade. It's a really good mystery show. My bad, not enough sleep. Brilliant show if anyone is interested. So, John, we have Dr. Philippe Merle in the studio with us this morning. So, Professor Merle, thank you very much for joining us. And for the listeners to know who you are, I thought, would you like to quickly introduce yourself and then we can go into the topic that you're going to be discussing with us this morning?
Hello, thank you to Zara and thank you to John for inviting me. That's a really pleasure. I am a medical doctor. I'm French, so I'm working in France, in Lyon. It's the third biggest city in France. And I was as a professor in hepatogastroenterology, digestive oncology. And I am working at the University Hospital of Lyon for a couple of decades. And my what I like in life, it's my work, especially liver disease, liver cancer, primary liver cancer. And the name is hepatocellular carcinoma and the so-called HCC. And I have devoted all my life, my professional life, to the clinical, basic, and translational research in HCC. It's a pleasure for me today to be with you to share some thoughts about what is HCC and how to treat HCC, how to try to be very useful for some patients.
Excellent. Thank you. So, Philippe, John and I met you some years ago as we were all working together. And again, HCC is something that John and I both also very passionate about. It's an area that we've always been very interested in. So this is actually a perfect trifecta to be having this conversation with you. And given HCC is it's such a massive topic, maybe you could highlight some key areas that you are very passionate about within research, and then how that can potentially impact patients' outcomes. And even specifically to France, there are challenges and some reimbursement issues that you may be confronting in France that may be different for us in Canada or the United States.
Yes. I think what is very interesting in HCC and liver disease is that HCC develops mostly on chronic liver disease and mostly on cirrhotic patients. It's patients who have chronic disease of the liver, either due to alcohol consumption or due to metabolic syndrome, due to viral infection, either by hepatitis C virus, hepatitis B virus, and global point of view, all the causes of chronic liver disease can lead, unfortunately, to liver cancer. So all the patients with liver disease are prone to develop sooner or later primary liver cancer or HCC. And that's why you have two types of disease at this time. We have first to treat the chronic liver disease, and the second disease, what we have to treat is the liver cancer. So we have charge of work as a pathologist and a charge of work as an oncologist. And I think it's very important to be expert in both fields to take care of the patient as well as possible.
You mentioned viral liver cancer is quite significant, Hep B, Hep C.
Yeah.
Does the recent vaccines and treatments reducing that incidence, or do you see reinfection and more liver disease?
Yes, of course. There's no vaccine for Hep C, but for Hep B we have one. And when we vaccine children, we are able to prevent the development of chronic Hep B disease and to prevent the occurrence of Hep B-related HCC occurrence. And for patients who have Hep B, chronic Hep B infections, we have some antiviral drugs. And with these drugs, we are able to reduce the multiplicity of the virus, the replication of the virus. So we are able to control the chronic liver disease. We are able to reduce the risk of HCC, but the risk is not down to zero. So it remains always a higher risk of HCC for the patients treated correctly with antiviral drugs. And for Hep C, it's quite the same thing. I mean, patients with cirrhotic or pre-cirrhotic chronic liver disease, even if we cure the virus, we can eradicate the virus with specific drugs. And although the patient are cured of the viral infection, of course, we reduce a lot the risk of HCC occurrence, but the reduction is not 100%. And there will always remain a higher risk to develop HCC. For instance, a patient with cirrhosis due to Hep C, if the Hep C is not treated, the risk of HCC is about 5% per year. If you eradicate the virus with drugs, the risk is not zero, but it is about 0.5% per year. It is not a lot, but for some patients, it's very important.
That's where patient monitoring needs to come into place, right? So patients need to be consistently monitored.
Of course.
And is this part of the education that you as a clinician share with patients, that they need to be closely monitored, they need to come in to check their viral loads?
Yeah, of course. I see the patient every 6 months with an ultrasound examination of the liver for life.
Okay.
And the patient, the youngest, in better shape, I see them at least once a year, but they perform in out clinics an ultrasound examination every 6 months. It's very, very important because most of the time, of course, it will happen nothing, but sometimes for some patients, HCC will develop. When an HCC develop, it's very, very, very important to make a very early diagnosis, because when the diagnosis is early, the tumor is very small and it's much easier to treat and to cure the tumor. Because one of the main issue with HCC at the beginning, it's completely asymptomatic. So up to about 7 or 8 centimeters of diameter of the tumor, there is no symptom. So that's why the patient do not have to wait for symptoms to consult the doctor. It's very important to have a systematic examination every 6 months by a physician and by a radiologist for ultrasound examination.
You're bringing up surveillance, which is a hot topic for me. Globally, the diets are changing around the world. Fatty liver is becoming more and more prevalent, and NASH, NAFLD is growing substantially. One person that I was speaking to was saying that it would outgrow the viral form of Hep C as the fatty livers grow if diet doesn't change, right? How is that impacting you in France? Is that generally on equivalent scale as what you would see in the Americas? Is there a difference, or is your incidence similar across France as other countries?
Generally speaking, all the things start in North America, and after they move towards Europe and Asia, and we have more and more NASH disease in France. And of course, with NASH, with the metabolic syndrome, we can develop HCC even without cirrhosis. Also, with alcohol, you have to go to cirrhosis first and after move towards HCC. But with NASH, you don't need cirrhosis to develop HCC. So that's a big issue. For patients without virus or with virus, when the virus is cured, if the patient drink a little bit alcohol if the patient, if they like life or general point of view. Because, you like good food, you like to have food with friends, so you're more prone to have a fatty liver disease and to develop HCC.
But just to follow along the lines of what John was mentioning around surveillance, so when it comes to metabolic liver disease, right, are there surveillance programs put into place right now for patients, like given that those numbers are increasing?
No,
What does that look?
that's a big issue, unfortunately, with cirrhotic patients, of course. If you have MASH-related cirrhosis, you have a surveillance program every 6 months. But for patients without cirrhosis, there is no recommendation. And that's why this recommendation, of course, should be written by the experts, but we have no recommendations. So every physician can do as he wishes. Personally, I make a close follow-up of patient, especially for men after the age of 40 years and for women after the age of 50 years. I perform ultrasound examination every 6 months.
As you mentioned, within liver disease, you have the factors that contribute to HCC, and we have the risk factors, but you can also develop HCC without risk factors. Maybe walk us down some of the treatment modalities that are now currently available in France for HCC and some of the challenges in accessing some of these treatment modalities.
So the modalities are very, very wide. It depends at the stage at which the diagnosis of HCC is done. There are different stages, stage 0, A, B, C, D. Unfortunately, for D patients, it's patients in very bad shape with poor liver function, huge tumor mass, with a very, very poor prognosis. And unfortunately, we cannot do anything for them. But the patients who are the most devoted to be cured with HCC are patients with early diagnosis. I mean patients with small tumors, either small nodule below 2 centimeters, patient stage 0, and it's very easy to cure the tumor either by surgery or thermoablation. And just after the stage 0, you have stage A, and in stage A, it's either 1 nodule, whatever is the size, or not more than 3 nodules if each of them is below 3 centimeters. And
Right.
in this case, we can still cure the patients, and it depends on the liver functions, depending on the age of the patients, on the general status of the comorbidities, will either cure the patient by surgery, especially patients with one big nodule. So surgery is the best treatment. Or if you have 2 or 3 small nodules, it's easier to treat by radiofrequency ablation, for instance. It's very easy, it's very safe, no problem. And for the patient who are rather young, and rather young, it means below 65 years, maximum 70 years, you can, and especially the patient that have a poor liver functions, it's a good indication for liver transplantation. And we have observed that patients that have liver transplantation with small HCC nodules, they have exactly the same survival that patients who have liver transplantation without any HCC. So we know that these patients are good patients for liver transplantation. And both you change the liver, so you have a new liver that as well, and you remove the cancer, and the patient is cured of the cancer. And what is important, when you have small tumor nodule of HCC, there is no metastasis. Metastasis occur mainly for tumors above 5 centimeters. Below 5 centimeters, most of the time, there is no metastasis. So it's not a problem.
The recent data coming out, Emerald 1, is intermediate. So the trials that you're doing in the neoadjuvant adjuvant in early stage disease where you're looking at combination therapy for enhancing that cure?
Yes, of course, because We know that there are patients who are eligible to surgery, for instance, who have a big tumor. And we know that for some patients, there are very high risk of recurrence post-resection. And for these patients, we try to combine systemic therapies like immunotherapy, decrease the risk of tumor recurrence after surgery. And there's a trial in Brave 050 in which we have the feeling it's not very convincing because I think the data are rather immature so far. We have to wait a little bit to have more mature data, but we have the feeling that combining surgery with immunotherapy, we decrease the risk of recurrence. The question is, do we have an impact on the overall survival? So far, it has not been demonstrated.
And so I think that's a good point you also bring in. I mean, so the other questions I was thinking, one is around the multidisciplinary team approach. We'd like to better understand what does that look like in your institution.
Mhm.
And then I think the second question I also had was with the advent of potential combinations coming in the earlier stage, what does that mean for sequencing therapies when those patients advance? If you give them combination therapy up front, when that
Of
patient
course,
advances, what does it look like?
no problem. Yes, the multidisciplinary approach is very important in the tumor board for HCC because we need the skillness of surgeons, of liver transplanters. We need the skillness of medical oncologists, of interventional radiologists, pathologists, and all of them are very important. And sometimes, for some patients who have several HCC nodules within the liver parenchyma, sometimes we can treat one part by liver resections and another lobe of the liver maybe by radiofrequency ablations. Maybe that the medical oncologist will say, okay, because there is a high risk of recurrence, I will start an immunotherapy. Everyone has a key role to play. The best management of each patient. Of course, we remove the tumor, we cure the tumor, but there is a remaining cirrhotic liver. So the cirrhotic liver that has developed a first HCC is able to develop a second HCC or third or fourth or whatever. We know that the risk of recurrence of HCC is more than 50% at 5 years. Because we have a very tight follow-up of the patients, we are able to make the diagnosis of recurrence very early and to treat very early the patient and to be very efficient.
If you're using Embrave 050 in that early setting, so how long would the relapse-free survival need to be for you to consider that we got a good response with this particular combination? The patient now relapses. Would you use that again, or would you move to Tremidura or now Nivo-Yervoy that's shown positive data?
Or even a single agent TKI?
Yeah. Yes, that's a very good question, but I think that nobody knows. Nobody knows. There is no study has demonstrated so far that they want to retreat the patients, and we don't know at all. For sure, in case of recurrence under adjuvant therapy by atezolizumab, of course, we can consider that the tumor is resistant to IO, at least to this combination. So maybe it could be sensitive to durvalumab. Why not? It isn't demonstrated, but why not? And the other case is when you have a late recurrence of the tumor. So what we call late recurrence most of the time is more than 2 years after the resection or after the thermoablation.
Okay.
At this time, we consider that it's not a recurrence of the first tumor, but it is the de novo development of a new HCC. When we re-challenge this HCC with the same IO combination.
Because there's less of a chance of resistance potentially developing in that.
Yes. Yes. And even when we treat some patient with advanced HCC by IO therapy, Sometimes we have many nodules within the liver, and we can see that some nodules respond very well to IO, are completely destroyed by the IO therapy, and others resist to IO and grow under IO pressure. So it is very heterogeneous within the liver.
I guess when you're discussing around resistance to IO therapy, specifically around HCC, what is the biomarker testing platform? What is the availability of biomarkers in within HCC? Do you have access to liquid biopsies?
Yes, of course, in research, in translational research, we have access to liquid biopsy, but we have for many, many years, a lot of teams have worked on biomarkers for HCC, and there is no real success in that. And the real biomarker that we use is only alpha-fetoprotein. But unfortunately, it is increased at very high level at diagnosis in about 1 HCC over 10. So it means that in 9 times over 10, it is useless. But when alpha-fetoprotein level is increased at baseline, it's very useful. And we can follow the efficacy of the treatment just by following alpha-fetoprotein level. But of course, it is in addition to the imaging, of course. Imaging either by MRI or CT scan.
It would be interesting for you to describe the difference between patients where you would use a combination versus monotherapy and what drives that decision for you when the patient's sitting in front of you.
It's very easy, because in IO monotherapy, it is not very useful. Because with IO monotherapy, just a few patients have response. For this patient with response, about 15% of objective response, we can get very, very nice results, of course. But the best is to use in first line systemic therapy a combination, either IO plus anti-angiogenic agent like beva, or IO, I mean like durva and treme combination. That gives good results in terms of median overall survival. So median overall survival is not very precise, of course, but it gives an idea on the efficacy of the drug. But I think that the median is not so important. What is very important, in the Kaplan-Meier overall survival curves, there is a late flat tail.
Right.
And I think in my mind, this is the most important because it's not only the rate of patients that we are able either to cure or at least to allow them to live a very long time. And the rate of long responders are very, very important. And we have data with durvalumab, for instance, and we know that for all the patients treated at 4 or 5 years, we have 25% of patients who are still alive. For some of them, very likely to be cured. That's very important because before having IO therapy, unfortunately, most of them at 2 years, had died.
The advances have come a very, very long way, but with that also, can you elaborate or discuss around the financial toxicities that patients would then be exposed to? Patients are also getting very knowledgeable. They come in, they've done their research as well. So what does that conversation look like when they come to you and they're requesting a certain treatment modality, but perhaps it's not the right one?
What is important? The most important is to have patient in good shape. I mean, ECOG 0 or 1, or a very small 2, and patient with good liver function. I mean, Child-Pugh or Pugh-B7, but usually we should only prescribe IO for Child-Pugh patients. By the way, life is life, and we do what we can, and we try to help every patient. So we treat sometimes some B7 patients. And for this patient, we in good shape with good liver function. Most of the time, IO therapy is very comfortable, is most of time very well tolerated, and most of patients have a good quality of life, for sure.
Sorry, these drugs are covered in France, like
Yeah,
the IO combination therapies? Okay,
yeah.
they're fully
The
covered.
two combinations are covered. And they have a very good quality of life. By contrast to patients on the TKI, TKI is not so easy to manage patients with TKI in terms of side effects.
Right. Okay.
And but in maybe in 5 to 10% of these patients on the IO therapy, we have, of course, adverse events. And in these adverse events, in 90% of cases, it's very easily manageable. And in 10%, sometimes we have big problems, sometimes life-threatening, like myocarditis or pneumopathy or renal failure, or sometimes with skin reactions, very severe skin reaction. It's rare, but it can happen, of course. It's very easy to detect as early as possible an adverse event. But we see the patient every 3 to 4 weeks, and it's very easy to detect uh, very early the occurrence of an adverse event, and we have to be very reactive in this case to treat the adverse events as soon as possible. Every physician can do what he wants. For concerning myself, for the most fragile patients, I give my cell phone so they can call anytime, and
Wow.
in a few seconds, I can help the patient very easily.
That's amazing. And thank you very, very much for your dedication to the patient. That's talking about that service that you're offering. What differences does your hospital make versus other hospitals? If you were out there talking to patients now, which you are, how would they find you, and what's different about your hospital in the treatment of liver cancer patients?
I have a team. It's not only me. I have a team. We have a network with my secretary, my coordinating nurse, and the nurse of my unit, of course, and the specialist of organs in my hospital. And there is a very efficient network to take in charge of the patient as soon as possible.
Did your institution cover everything from liver transplant right through?
Yes, of course, we have university liver center, and we treat the patient, of course, for cancer and for liver transplantation, viral hepatitis. So we have some physicians, not me, have expertise in Hep C, others in Hep B, others in alcohol, in addiction, others in MASH. So we have all a very precise goal in our work, and a very precise perimeter where we can work, and we are all complementary between us. That's the way with which we work.
Sounds like a fantastic MDT for patients to find out about.
Thank you, John. As always, it's been a pleasure. We will chat with you soon, my friend.
Catch you later.
Thank you.
Okay.
Thanks,
Thank
listeners.
you. Thank
Goodbye.
you, Philippe. Bye-bye.
Bye. Goodbye from Med Insights Unleashed.
Have a good day.
Med Insights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. Med Insights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next Med Insights Unleashed podcast.